This is Chapter 18, Rehabilitation of Elbow Injuries. Much like previous chapters, we will start with some pictures of the anatomy. Please make sure that you have reviewed this accordingly. Third anatomy slide shows the carrying angles. Naturally, both males and females have a little cubital valgus. Average female carrying angle is 10 to 15 degrees, while males tend to be around 5 degrees. Less than 0, you have cubital varus. If you have significantly more than 0 degrees of cubital varus, like the picture on the far right, that has a gunstock component. Many times, this can be the result of a supracondylar fracture. As you are listening to this, make a quick inspection of your carrying angle bilaterally. Even though you probably don't have a goniometer handy, you should be able to eyeball the approximate degrees to note if you fall within the normal range for your sex. The next two slides have not changed. Hopefully I have made my point. The next slide discusses some of the potential injuries of the elbow that will necessitate rehabilitation. First listed is somewhat broad because there are many places you can fracture your elbow. All three bones that make up the articulation could be broken with various mechanisms. Twisting or torsion with a hand fixed, direct impact, and falling on an outstretched pronated arm are all causes within the wide realm of sports. Just like any other fracture, you need to stabilize the bony discontinuation, or any form of exercise or activity should occur. This means you have the standard 6 to 8 weeks of healing if there is no fixation, but that inactive period is maybe 24 hours with an ORIF repair. As directed in the book, if there is a stabilizer for the fracture, simple range of motion exercises can start almost immediately after the surgery. From there, similar protocols to any body part should be followed. Full and pain-free active range of motion should be achieved as you begin to progress into isotonic strengthening. Once open kinetic chain strength is near baseline, you can begin to do more closed kinetic chain exercises and plyometrics. Through all of this, as is the case with all of these elbow injuries, you will need to be sure the shoulder and wrist remain viable. The next bullet lists osteochondritis dissecans. Painter's disease is also noted under the bullet. Osteochondritis dissecans is a condition that affects the central and/or lateral aspect of the capitulum, or radial head, in which an underlying osteochondral bone fragment becomes detached, forming a loose body. Early teenage pitchers, gymnasts, or even basketball players may sustain enough repeated trauma to develop this condition. Painter's disease is found in even younger individuals. It is an osteochondrosis of the capitulum that can cause softening or fissures in the articulating tissue. You can see how that softening could result in osteochondritis dissecans. The biggest consideration for osteochondritis dissecans is that the loose bodies are probably creating problems, so surgical removal of the loose bodies is warranted. After the surgery, the progression is going to be a little more rapid than the elbow fracture we talked about previously. The next injury is the famous ulnar or medial collateral ligament sprain of the elbow. This can happen acutely from a valgus force on the elbow or from repetitive chronic microvalgus stresses, such as with a pitcher or javelin thrower. The UCL is most vulnerable at the amortization of the throwing motion, the point between the eccentric cocking and the concentric throw. Typically, the mechanism is a straw that broke the camel's back. The throw that incites the symptoms is usually not something that is very extraordinary. The patient will report specific pain or discomfort in the medial elbow. They may report a pop or snap felt or hurt. There will likely be some neurological symptoms noted. If there is a grade 3 sprain of the elbow UCL in a throwing athlete, they will need surgery to return to their previous form. In non-pitchers, such as an infielder in baseball or softball, you may or may not need surgery. For someone who is a designated hitter only in baseball, you probably would not need to perform surgery. If you look at the book on page 533 and 534, they discuss the progression of the individual post-elbow UCL reconstruction. In my experiences, the timeline they describe in the book may be a little aggressive, especially for a higher level pitcher. They state that 22 to 26 weeks, about 6 months, is when you would start competitive throwing. I have not really heard of that rapid of a progression post-surgery, but I am also not intimately involved with many post-UCL surgeries nowadays. My thought was that the competitive throwing started around 8 or 9 months. In looking at some of the protocols out there, there seems to be a wide variety, with most starting the competitive throwing between 6 and 8 months. Know the surgeon and understand where the patient is on the spectrum of throwing athletes. Let's take a high school junior pitcher with a grade 3 elbow UCL sprain. If the patient feels they are capable of being a pitcher past high school in some capacity, you will probably be a little more conservative and prolong the rehab post-surgically. If that high school junior does not have any desire to pitch after high school, you may not even worry about surgery and transition out of being a pitcher. They can follow an aggressive rehab protocol and get back to participating in a few months. Nerve entrapment is the next potential injury to discuss. The ulnar, radial, and median nerves may all be entrapped in the elbow area. The ulnar nerve is susceptible to injury from valgus forces, much like those we just discussed in the elbow UCL injury. The median nerve can be entrapped due to hypertrophied pronated caries, which happens in racket sports. Repetitive pronation and extension of the forearm tends to be the problematic motion. Radial nerve compression may be found in overhead activities like swimming and tennis. These symptoms mimic lateral epicondylitis, which we'll talk about soon, but the tenderness is distant to the lateral epicondyle. One other thing to note that may separate median and radial nerve entrapment from other diagnoses is night pain, which is common with these pathologies. As far as rehab considerations, try to remedy the entrapment with manual therapy to alleviate any hypertoned muscles or trigger points, aggressive range of motion to limit restriction, and then appropriate strengthening to maintain appropriate balance between the elbow and forearm musculature. Surgical intervention will require a splint for assistance in resting the area. The usage of the splint is progressively decreased throughout the first week or two of post-surgery until complete discontinuation around 3 weeks. Elbow dislocations are the next topic. They can be very traumatic injuries. They also tend to be some of the most gruesome that we see, outside of the lower leg fractures that they replay on ESPN a dozen times. The falling on outstretched arm mechanism applies here. There are many elbow dislocations in wrestling. The one that I have seen firsthand was a youth soccer goalkeeper who hit his outstretched arm on the post diving to save the ball. The likelihood of subsequent dislocations or subluxations after the initial elbow dislocation is very low. Exceptions are if the first dislocation occurred while the patient was physically immature and or there was an associated fracture. After reduction done by a physician, you will immobilize for a few days. One thing you can do is risk or grip strengthening while splinting. You may even do shoulder isometric exercise while in the splint. Once the splint is off after about 10 days, the protocol is like any other. Meet the early goals, then build on those by progressing through the exercise recovery. Medial and lateral epicondylitis are next. What do we know each of these as in sports terms? Medial epicondylitis occurs commonly in golfers, racquetball, or swimming in adults. This is also called little leaguer's elbow in adolescents. Repetitive microtrauma to the flexor mass and pronated teres during pronation and flexion is the reason. In golfers, it will be your trail arm in your swing that is problematic. In right-handed hitters, that would be your right arm. In the little leaguer's elbow, the mechanism is like an elbow UCL sprain. The amortization phase of the throw over time creates trauma to the medial side of the elbow. As we just discussed, ulnar nerve neuropathy may be present in these cases due to the stress on the pronated teres. Lateral epicondylitis is what we commonly know as tennis elbow. When you have forceful wrist extension of the tennis backhand, this can develop. In young tennis players, they use too much wrist to pull off the backhand. In more mature tennis players, the use of a topspin backhand shot puts more stress on the extensor muscles. Appropriate tennis racket tension, appropriate grip size, and keeping tennis balls dry can also minimize the chances of lateral epicondylitis. The book mentions 2 approaches to these injuries. These approaches can be applied to any inflammatory condition, not just these 2. One is treating it like any other injury we have discussed and reducing inflammation and moving forward with the repair and remodeling phases. The next, which is something that we may do in clinical practice more than we realize, is trying to break a cycle of inflammation that is stuck in the acute phase. This will be done using methods that will increase the inflammatory response. What are some of the manual therapy methods we use to do this? Also remember that in these cases, cryotherapy is really not warranted, since the point is to increase the inflammatory response. There are some clinicians who abide by this second technique for every injury. Your clinical practice can inform your decision on how you wish to treat injuries. The last two slides show tables from the book regarding healing progressions. They are relatively straightforward, but we will discuss them in class.